Hello and welcome to Empower 2020, a Frontier Nursing University virtual event to celebrate the Year of the Nurse and the Midwife and celebrating National Nurse Practitioner Week. My name is Billinda Tebbenhoff and I'm going to be presenting tonight on anxiety in children and adolescents, looking at assessment but focusing on trends in treatment. Our objectives for this presentation are to understand the continuum of anxiety responses in childhood, so from birth to late adolescence, and how that can carry over into adulthood and the entire spectrum of life. We're going to look at some of the biopsychosocial factors associated with both the pathogenesis of anxiety disorders in children and adolescents and the natural anxiety response as well. We're going to compare some of the treatments for anxiety disorders in children and adolescents, how those vary a little bit related to developmental age, and also physiologic differences that helps guide our pharmacologic treatment. And then finally, we're going to evaluate some of the impacts that we have so far. We have very little data, but data is starting to come in about the impact of the SARS-CoV-2 COVID pandemic on children and adolescents in relationship to mental health overall, but specifically with anxiety and anxiety disorders. So let's start at the top and talk about the definition of anxiety. Obviously, it's a term that we all use, but what does it really mean? And then we have several definitions of it, and we're going to look at some of those before we launch into our conversation. So anxiety at the highest level, sort of at the, pan as far back as possible, anxiety is an expected response to a novel stimulus. So anxiety is something that we feel when we encounter something new, something that is different to us, or something out of what's expected. That's kind of the natural response. It gets our attention. We're like, wait, this isn't what I'm used to. And our brain and body and memory needs to make sense of whatever that stimulus is. So we'll carry that forward, but anxiety is an expected response to a novel stimulus. So if we look at some of the functional aspects of anxiety, we really focus on time frame, right? So episodic, temporary, manageable anxiety can enhance our attention for learning and performance, right? And this makes sense to us when we think about a professional athlete, right? They don't get ready to go into a game and they're like super relaxed and chill. They need to be energized so that they can perform. If we're getting ready to go into a test, we don't want to be too chill about that and kind of disengaged because we're not going to perform our best, right? We know these things, but to focus on sort of the functional aspects of anxiety, because sometimes anxiety can be all the villain, right? And when we talk about anxiety disorders, we will be focusing on that. But anxiety is sort of a normal context, a normal experience in the human experience. So I guess the takeaway from this is that we can't avoid it. We can't avoid anxiety in life, but what we can avoid is extreme anxiety and impairment, socially, functionally, relationally. That's what we can change. All right, so let's think about anxiety as a developmental construct. We already know that anxiety is part of the human experience. We can't avoid it. And when we think about development in anxiety, right, we know that something like separation anxiety, this is a normal, expected developmental response in children when they realize that someone that they love, a caretaker, someone that they really rely on for safety, protection, love, happiness, has stepped out of the room or has left for a period of time and hopefully returns. But it's a reflection of a normal response to object permanence, right? And if you remember in development, how we develop object permanence, right? Like for a while, peekaboo is so fun for children because when you cover your eyes, you disappear. As the child develops that object permanence, they know you're still there. And peekaboo is less of a thing because they know where to find you. But so that type of anxiety related to caregiver protection is a normal response and a normal milestone. There is pathological a disorder of separation anxiety, which we'll talk about in a little bit. But this part is normal. We usually see it within babies like around 9 months, plus minus, and it may peak at 15 to 18 months. But generally, as the child develops coping strategies to tolerate that separation, it becomes normalized, and the child learns that, you know, people I care about can go away for a little bit and then they come back and everything's okay. They learn to internalize that response, and it's adaptive and resilient. This is sort of a little bit of everything, because when we think about the normal development of anxiety, we talked about anxiety, separation anxiety, and how that's sort of a developmental construct, and how we think back to anxiety being a normal response to a novel stimulus. Think about a moment about how hard it is to grow up, right? And that in those early years of life, everything is new. So we encounter school, we encounter preschool, we learn to walk, we learn to run, we go to grade school, we develop new friends, we enter relationships, we enter adolescence, we work for the first time, we drive, we fall in love, all of those things that are necessary, important, beautiful, and sometimes sad things in life that we are encountering for the first time. So that's just part of development, right? We were all babies once. We've made it this far. We've made it through some of those bumps in life, and they'll continue for the duration of our life. But when we think about anxiety as that novel stimulus paradigm, we are incredibly adaptive and incredibly resilient. And so when we think about talking about disorders, this is when it goes to that next level of causing significant impairment in life and impairment in love and development and all those wonderful things that life has to offer us. So let's talk about, we talked a little bit about terms, and let's think about anxiety in the context of research, and when we talk about it being a little bit more than that expected anxiety that we have in life. And in research and in earlier constructs of anxiety, the science kind of divided into two aspects: the issue of fear and the issue of anxiety. So fear, as is defined there, was identified as a response to a threat, right? A response to a threat. We perceive something to be a threat to us. Our response is fear. It is adaptive, right? We are mammals, right? We're pack mammals, as a matter of fact. So we have a fear response to a threat. It's adaptive. Anxiety, in its earlier constructs and still, is considered to be the anticipation of a possible threat. All right, so that reflects a little bit of learning, right? We're exposed to something that creates fear. We want to learn from that. So the anxiety responds to that anticipation of a possible threat. So one of the challenges with that model in considering those terms, and research has built a lot on those two constructs. The problem is that these definitions focus on the threat, sort of the stimulus, and not the person. So as we consider, obviously, individualized care, people will have different responses and different fears and different perceptions of threat. And that's okay. But the point at which those get in the way of life, that's when we look at treatment aspects. In our conversation today, we won't be talking about trauma. Trauma used to live under the umbrella of anxiety disorders in previous Diagnostics and Statistics Manual DSM-3 classifications. It now lives in its as an entity, a separate entity, and rightfully so, because of everything that we've learned about trauma and the science of trauma. So we'll make mentions of trauma today, but we will not be diving into treatment aspects of trauma specifically. Another group of disorders that we will talk about, but lives in sort of its own separate diagnostic category now, are the obsessive compulsive disorders. And the reason we are talking about those in this presentation and not trauma was mostly because of the treatment overlap of OCD as far as medications. We have quite a few medications that are approved for use in children and adolescents that are approved for obsessive compulsive disorder, and we can use them off-label in children. So just a little bit of what we won't cover, but we will be focusing on those anxiety disorders. So the expressions of anxiety, what a person might identify that they feel, and then what we might outwardly see as those expressions are important to think about, because families will come to us, with reports of certain behaviors or certain expressions that a child or adolescent might have made about their situation. And then once we have a chance to interview the child and the adolescent, they have their own expressions and interpretations of what that anxiety is like for them. Sometimes the inner experience or labeling of anxiety by a child or adolescent, we might hear words like, I'm really worried about this, I'm really scared about this. These are terms we would expect to hear, right? I'm nervous about this thing, I'm nervous all the time, I'm too nervous to go to bed at night. We hear children identify that they're afraid. Fear, again, is kind of a common and expected response to different times in development. But if it is a chronic theme or fear, being afraid of many things, we will ask some more questions about that. Sometimes adolescents will say, I'm feeling crazy. I'm feeling crazy. I'm super stressed out. I'm distracted, and that concept of nervous in there twice bears repeating because it's a common expression. Now, when we talk about that inner narrative, so in children, right, they learn from their environment and their family ways to label certain things. So lots of times they might have the family narrative or whatever the anxiety has been called. And we'll talk about that later when we talk about some cognitive behavioral interventions, because we definitely want to label the anxiety, the fear, give it kind of an identity so we can kind of use cognitive restructuring to kind of defeat that, give it a name and take power of it. Now, some of the outward expressions is what we need to rely on a little bit more, particularly in younger children, because they might not have great insight and they have more limited vocabulary of kind of expressing their inner experience. So lots of times, particularly in younger children, we'll see more often the presentation of physical complaints, such as headache, such as stomach ache. Stomach ache is a common one. We might see bowel changes, might see constipation or diarrhea with a child that is experiencing significant anxiety. They might talk about their heart fluttering or racing, or that it's beating hard against their chest. They also might complain of muscle pain, which again is not uncommon in children as they grow. Growing pains are a thing, but this might be more of a vague muscle pain, or they might talk about tension. Adolescents too, definitely. I've got this like tension in my neck, or the headaches that we mentioned earlier. Stomach complaints and concerns are very, very common, and there's a fair bit of literature out there about seeking care for stomach concerns, particularly in girls around 9 to 12. Common complaint that obviously we have to rule out all medical possibility for what might be causing the discomfort or the GI changes, but often associated with anxiety. And the pediatricians, GI specialists often now weave in sort of some anxiety management overall for good health, and certainly for kids that are experiencing some of that GI and stomach discomfort and distress. So let's talk a minute about temperament and anxiety. So temperament is sort of that inborn who we are kind of interaction, how we approach the world. Some people and children are a little more behaviorally inhibited. So maybe a little bit more shy, maybe a little bit more guarded in social situations, kind of like expand, like want to check things out before they engage and play, or asking questions. They might process things and not ask a lot of questions. Other children and adults, people are a little more gregarious, and they jump right in, and they've never met a stranger and will talk, candidly with people that they don't know very well and feel very confident. And that's just temperament. And temperament is not a pathology. And that's important because there is some literature that looks at behavioral inhibition, caution, shyness, as associated with anxiety. The literature supports that maybe 10% of people who have behavioral inhibition might develop an anxiety disorder. What I want to communicate is it's not a given, right? If there is someone who is shy and cautious, they are shy and cautious. That is who they are. But just wanted to make you aware that there is that literature out there about behavioral inhibition. And this behavioral inhibition, temperament is sort of, comes with you at birth. So children who are a little bit more behaviorally inhibited can even show things in infancy, like a very exaggerated startle response. They might be a little more reactive to environmental changes or any sort of change in their usual routine that might be a little more unsettling to them than other children. So there has been a link. We don't have a specific gene that we can point to with absolute certainty, but just to know that some of those temperament issues, behavioral inhibition, is associated with anxiety and potentially anxiety disorder. It's not that definitive. If someone has a child who is shy and cautious, that is A-okay. All right, so anxiety disorders and other disorders. Let's talk about that for a little bit, because anxiety from a disorder standpoint, and we'll go through the specific DSM disorders and talk a little bit about what their symptomatology is. Anxiety can be primary or secondary, and I want to really highlight that commonality with anxiety and depression. There are components of anxiety and depression and vice versa. And sometimes it can be really hard to tease out, but that just to know that link between anxiety and depression is very close. Good news is in treatments, lots of times we can have interventions that will address both of them, but wanted to point out that link between anxiety and depression. We know that there are medical conditions that present as anxiety disorders, and the ones that are relevant to children include lead toxicity, diabetes. Sometimes initially can be presented as anxious kinds of symptoms, and autoimmune disorders. That is consistent through the lifespan. Probably fewer autoimmune disorders in children, lupus, for example, multiple sclerosis that we usually see a little bit later in life. But those conditions in adults, interestingly, sometimes there is a documented onset of depression that precedes actually the autoimmune symptoms, anywhere from 5 to 10 years. So that just highlights to make sure that we talk about health as health in its totality and not divide out what's a medical condition, what's a mental health condition, right? We're looking at all these things together. Some of the other psychiatric conditions that may present as anxiety, we talked about depression, substance use disorders. If there is alcohol or other types of substance use, sometimes anxiety is a presenting feature, either because of dependence on the substance or related to the specific substance itself, or to an attempt to decrease use of the substance. Since we're talking about children and adolescents today, it's important to make a note about learning differences. and the impact of learning differences on anxiety. And for everyone who is an educator out there of young children, hats off to you. And knowing that there is a change in learning that happens, an expected developmental change, of a period where a child is learning to read, right? Lots of emphasis in the early school years about learning how to read, the mechanics, building vocabulary, and all those important things. And then in slightly later grades, there's generally third or fourth grade, there's a switch where a child goes from learning to read to reading to learn, and that those skills of mastery of reading are required to get the information to learn more complex information. So for some children who have fluency issues or learning differences, that can be a time where performance changes for them. Maybe school is very easy, school changes from now suddenly to being very hard. And sometimes it's hard to sort out because obviously content gets harder the more as you advance in grades or whatnot. But that can be a key time where the anxiety, a family will come in and a parent will say, that my child was just doing great in school, like in first and second grade, and then around third grade, things really changed. And anxiety increases. Now there's school refusal, child's not sleeping at night. I would probably be encouraging maybe an evaluation for a learning difference and get the necessary accommodations to make school pleasant again and help with any resources that are needed. So I did mention today that we are not going to be talking specifically about trauma and treatment of people who are survivors of trauma. But I do want to make a mention about trauma-informed care, which should be a part of every type of care that we offer for any condition, medical, psychiatric, all of the above. And just as a review, those elements of trauma-informed care include safety, making sure everyone feels comfortable and safe in the care environment, trustworthiness and transparency, being clear about what the process is and interviewing, history taking, and being able to be trusted and transparent in what's happening in the process, peer support, collaboration and mutuality, empowerment, voice, and choice. The patient, and since we're talking about children, part of the care team now needs to be informed to the highest of to the best of their developmental ability to go along with treatment care, the treatment plan, to agree to it, to adhere to it, and to reevaluate it. And also aspects related to cultural, historical, and gender. So those are a review of those trauma-informed care elements that are part of every care encounter. So let's talk a little bit about screening and assessing anxiety disorders. We have just a few of sort of the screening tools that are used most commonly for screening and assessing anxiety disorders in children and adults. And just for the sake of brevity, just put the name, overall content. These are all free, so they're in the public domain to be used, and then a note about any helpful information about them. So the first one that we're seeing a lot in all types of care, primary care, across the board, is the use of the GAD-7. GAD-7 set of 7 items, self-report of overall sort of general anxiety symptoms. This scale is appropriate for adolescent through adults. It's free, as are all of these. And the GAD-7 is also available for easy download in multiple languages. This is something that we often give to patients as they're coming in, waiting for their appointment, or send to them in advance to do just a quick screen. Another scale is the Spence Children's Anxiety Scale. This is the SCAS. This scale is nice because it has a preschool version as well as a child version. It is self-report. And there are some visual cues for it for the very young child. They'll certainly need a little bit of help completing, of course. And this one is free also. Probably the most common screening and assessment tool we see for children and adolescents for anxiety disorders is a screen for child anxiety-related emotional disorders, abbreviation SCARED, acronym SCARED. And this is a parent and child self-report for generalized anxiety disorder, separation anxiety disorder, panic disorder, social phobia, and a special section which is really useful for school phobia. School phobia is not a specific entity in and of itself. It has been in previous diagnostic classifications, but this tool does a nice capture since school phobia and school refusal is so common in relationship to anxiety. So the age for the SCARED tool is 8 to 18, takes approximately 15 minutes to finish. So pretty straightforward and quick. And again, the one we probably see most often in research. And the last item there is the Y-box, the Yale-Brown Obsessive Compulsive Scale. I did mention we're going to talk a little bit about obsessive compulsive disorder because of its interconnectedness to anxiety, and also because it's one of, there is a subset of these disorders that appear to be infection mediated, and so I think it's of note to include them. This is a 10-item semi-structured, so it would require somebody that has some training to administer the Y-box. And it too has been validated and is available in several languages. So let's switch gears and talk a little bit about the biopsychosocial aspects of anxiety. So here we're going to talk a little bit about the neurobiology, neuroanatomy, just a very high level overview. We're going to talk about some of the psychological aspects, some of the social aspects, and this would be the totality of the anxiety response, as well as specific disorders, sort of what we might see as normal, what's activated, and then what gets to be more of a disorder. So let's talk about neuroanatomy of the anxiety response for a second. So starting big, and anxiety, and it makes sense, right? We talked about the adaptive nature of it and the mammal factor of anxiety. A lot of the brain structure and processes are related to anxiety response. It is a big part of what the brain does, and that makes sense, right, from a survival standpoint. So when we talk about neuroanatomy specifically, we usually focus on the temporal lobe and then specifically the limbic system. There are 6 subcomponents, general components that we talk about that. I'm going to focus on 3, and that would be the amygdala, the hippocampus, and the hypothalamus. It's important, mention there those last 3, the basal ganglia, the cingulate gyrus, and the thalamus. Won't have specific mention of those, but it is interesting in the basal ganglia. We'll talk a little bit about that with obsessive compulsive disorder because that's also associated with movement. When we talk about children with Tourette's syndrome or who have tics, this highlight area is the basal ganglia. But for this presentation, we're going to focus on those top 3. So a little bit about the amygdala. The amygdala actually has 2 lobes, it has a right lobe and a left lobe. And what's kind of fascinating about those is that those develop at different times, and there's also slightly different neurodevelopment between males and females. And sometimes the literature has looked at that, and maybe whether or not that's relevant to the fact that more women are diagnosed with anxiety disorders than men. Might be a neurodevelopmental component, I'm not sure. The left lobe develops a year or two before the right. And the purpose of the amygdala is to detect danger. The amygdala is also vitally involved in storing emotional memory, right? So when we think about those responses, right, that's housed in the amygdala. And then also to activate the stress response system of the hypothalamus. The hypothalamus activates the endocrine response, and we'll look at that whole loop in just a second of the hypothalamic pituitary adrenal axis. but that's what the hypothalamus triggers that. And then the hippocampus is also associated with memory and learning. I always tell my students that I remember the hippocampus is memory because I say hippos never forget. It's actually elephants that don't forget, but anyway, whatever helps us remember neuroanatomy. All right, if we look now at the neurophysiology of anxiety and some of the neurotransmitters, this will likely be a review, but GABA is our primary inhibitory neurotransmitter, gamma-aminobutyric acid. And remember, sometimes that can be confusing, the direction of it, right? So if we have more GABA, we're more chill. And if we have less GABA, usually we're thinking about reducing things to decrease symptoms. But if we have reduction in GABA, right, we would have more anxiety. Norepinephrine, involved in sort of that autonomic response, serotonin, 5-HT, dopamine, and glutamate. Again, a big response because from an adaptive standpoint, anxiety is important to the survival instinct. So here is a diagrammatic of the stress response system, and notice that it is a loop, and it should work, when it works, should work by negative feedback. So in the initial response, the hypothalamus triggers corticotropin releasing hormone, which stimulates the pituitary gland to stimulate adrenocorticotropic hormone, which results in the production of cortisol. And we will all remember cortisol as cortisol is a good thing. It allows us to respond, it releases glucose, it helps us, when we're in that mode of activation, right? Cortisol is really, really useful. The problem when we talk about a stress system that doesn't shut down is a state of hypercortisolemia, which we know has implications for the inflammatory response and also insulin resistance. So when this works, it works well. If we perceive a decrease in stress or decreased threat, this system turns down, decreased production of cortisol because the threat is resolved. Some of the concern about models of chronic anxiety and stress is that our bodies can no longer turn the off switch, so that we're in this constant activation. Ideally, there would be a decrease in that perception, like we were talking about, all systems shut down and are sort of recovered and ready for the next possible threat. Under chronic conditions, this is where the system burns out. Interestingly, and though we're not talking about trauma today, people who have this hyperstimulation and have experienced extreme trauma, over time, this system can be completely exhausted. And if we were to evaluate someone's cortisol physiologically, there would be a blunted response, and there might be cortisol values of almost nil. The very good news, though, is that with treatment, this system can recover, and even people who have experienced extreme trauma, who are successful in treatment, can sort of reset. So that's always hopeful and encouraging news that even in extreme states of stress and an exhausted stress system, recovery is possible, full recovery is possible. So let's transition a little bit and talk about some psychological factors. So anxious parents have anxious kids. That's kind of a very global, specific statement. And it is true that anxiety, we've had that conversation about, people will say anxiety is contagious. And when we talk about infectious possibilities, that's really more true. But we respond to anxiety. I'm sure we've all been in a situation where something, scary happened or something, and everyone is activated, right? We're responding to the environment and things that are happening. So it kind of makes sense that there are elements of an anxiety response that are learned. There are different perceptions of threat. There are different responses to anxiety-provoking events. So from a psychological standpoint, some of those behaviors can be learned. And literature generally supports that about 50% of anxiety disorders have heritable factors. Now, that doesn't mean that 50% of people who live in a home where there is one or more anxious parent, one or two anxious caregivers or parents, doesn't mean that they're going to develop an anxiety disorder. It just means that there are aspects of anxiety disorders that are heritable, that have heritable factors. And it's interesting to note, we talked about temperament, kind of an inborn, response to the environment, the world, cautious, interactive, all those things. Sometimes there is a familial disconnect or fit, right? Because sometimes a super chill child is born into a very anxious family. And the super chill child is thinking, I don't know what the problem is here because I think everything's cool. And then vice versa, a very chill family can have a temperament of a child that's particularly anxious. And there can be just a kind of a struggle or a feeling like that can be isolating for the person who has different perceptions based on their temperament. So different perceptions of risk and risk appraisal and worry. So we know that those psychological factors have impact. And by that same token, the reverse can be true, right? If people are addressing their anxiety, that can have an impact as well. So let's talk for a minute about some social factors that are related to anxiety and anxiety disorders. First and foremost, we need to consider always cultural factors that are related to the perception and expression of anxiety. To have dialogue with our patients and understand those and the best approach for interventions for that. Another very important topic that is so prevalent now that we need to really take note of and research well and provide excellent care are the aspects of things like systemic racism, to appreciate the experience of people who are descendants of enslaved persons. And our models include looking at some research that has been done by the descendants of research that's been done on the descendants of Holocaust survivors that show evidence of genetic changes, actual genetic changes in the descendants of those people who were in the Holocaust. So actual changes in the FKBP5 stress gene. So we'll hope that there is much more work in this important area of these social factors. So let's talk now about the specific anxiety disorders that we see in children and adolescents. And for those of you in practice, you'll notice that these disorders are similar now they're across the lifespan from a diagnostic standpoint. And then we make note that they're happening in a child. There used to be in earlier versions of the DSM completely separate section, and we do have developmental disorders that are in a separate section of the DSM, but when we talk about anxiety, there will be some similar diagnostic features, of course. So one of the first disorder we're going to talk about is separation anxiety disorder. And this we mentioned a little bit. Remember, separation anxiety in and of itself is a developmental construct and expected in development. When we talk about separation anxiety disorder, this is an intense fear of being separated from someone that the child or the teenager is very attached to, and that the anxiety of being separated from them causes significant impairment and avoidance. We'll hear these themes throughout the diagnostic criteria of avoidance, intense, extreme. Selective mutism is kind of a disorder that's a little bit by itself. It involves communication, and it's actually a refusal of a child to speak in specific situations, even though the child has ability to speak in those situations. Though it's relatively rare, the presentation is usually that a child who has an expected fluency and has no known difficulty in the ability to speak has sort of internalized rules or reasons that they'll only talk to certain people, or they'll only talk in specific situations. I've had the opportunity to see some children who maybe could only speak to grandma on a certain phone on a certain day and would not speak to anyone else at any other time for any other reason. Selective mutism has, because it is relatively rare, there's not a lot of outcome data. Usually over time, there can be, sort of stress reduction techniques that are incorporated to understand more about dynamics and what the basis of the child. And also, if they are unwilling to speak to the therapist, we need to be creative and having other ways to communicate, and whether or not they'll nod or, infer some way to communicate. So that can be a challenge. So that's selective mutism. Agoraphobia is the significant fear of being in open or closed spaces, crowds, public transportation. But the overriding theme in agoraphobia, that the fear is due to the fear of not being able to get out of or escape the situation. There is a very symbiotic relationship between panic disorder and agoraphobia, which we'll talk about in just a second. But the overall, and what happens with folks with agoraphobia over time is their world just gets smaller and smaller and smaller because they're worried about this ability to escape. So they maybe don't go out of the house, and then maybe the house gets a little too big and there's only one room that they seem to be particularly safe in. So again, sort of limiting as far as social activities, work, and that kind of thing. We don't usually see agoraphobia in children. We will see sometimes the onset in later adolescence, around 17 is usually kind of the age that we see most agoraphobia onset, but again, rare in childhood. So generalized anxiety disorder, also known as GAD, this is a consistent, intense worry about almost everything, or many or most things. It's very often associated with physical symptoms, sleep disturbance, just sort of that overall worry. And what's interesting about generalized anxiety disorder, often time from acknowledgement to treatment is around 10 years. And very often people will not seek help for generalized anxiety disorder because they more often than not consider it to be just like who they are. And so it might be something else that happens, either a depression or some other symptoms that begin to happen, or the worry gets that much worse, really impacts sleeping, or causes significant, stomach pain, that kind of thing that brings someone in. And this is that worry, again, about sort of everything. An example, mom or dad will hear sirens, and they call their loved one, I heard sirens, are you okay? And kind of can take things that we normally wouldn't think about, things to worry about. Obviously, we worry about the people we love. This would be sort of a step kind of beyond that. Obsessive compulsive disorder. So remember that obsessive compulsive disorder used to live in sort of this overall umbrella of anxiety disorders. It's now its own cluster of disorders. So I'll make a note because we're going to talk about a few more that live under this umbrella of obsessive compulsive disorder. But it's noteworthy because obsessive compulsive disorder often starts in school-age children. Usually boys have an onset a little bit younger than girls, generally ages 9-ish. There was also a triad of early onset of ADHD, OCD, and then tics and Tourette's. This triad of symptoms that can happen. That's not to say that a child that develops ADHD will always develop OCD or tics or Tourette's, but there are some children who develop all three within a year or so of each other. And obsessive compulsive disorder, the hallmark there are repetitive thoughts and behaviors. So obsessions like my hands are dirty, I have germs, and then the responsive compulsion is excessive washing. In total, the obsessions and compulsions together consume at least 1 hour of the person's day and interferes with life. In children, the obsessions don't necessarily have to be voiced by the child, because they might not have that insight of why they do these behaviors, but we'll see sort of those consistent compulsive behaviors. Now, just to make a note that this is not to be confused with normal kids collect things, kids organize things. You know, if you've ever watched a 3 or 4-year-old lay things out and line it all up and then line it up again, that's how they learn. That's not obsessive compulsive disorder. There's usually 1 or 2 things that are like consistently done and have like a very sort of ritualistic, exact same way kind of thing, and it causes distress. Sometimes it can be hard to differentiate, but earlier in life, that's how we learn things, by doing things over and over. This is a little bit different than that. And that note at the end, 25% of all adults with OCD have a childhood onset, even though they might not officially be diagnosed until they're in adulthood. Body dysmorphic disorder falls again under that umbrella of obsessive compulsive disorders. And this is notable because we see this definitely in adolescents, particularly adolescent males, where it's a preoccupation, and again, sort of beyond what we usually expect. We know adolescents, their bodies are changing, they're concerned about how they appear to their friends and that kind of thing. But this isn't a preoccupation, like can't think about anything else kind of thing. And it's usually about a specific bodily feature that seems to be flawed to the adolescent, but is not aware to anyone else. For instance, I've heard adolescents say, so do you see this, my eyebrow? My right eyebrow has this little notch in it, and they'll make some notation, and the other person can't see it, but the adolescent can't think about anything else, and they feel like they are just like horrible and unpresentable because they have this flaw, even though no one else can see it. This can cause significant impairment. Sometimes adolescents drop out of school, stop talking to people because they feel that there's something wrong with their appearance that can't be fixed. So it can be very disruptive for life. Hoarding disorder, we hear more commonly in adults, but in older school-age children, generally 11 and up, we could begin to see sort of this, and again, this isn't normal collecting, right? Kids collect, they collect rocks and fuzz and glitter and all kinds of cool things. This would be saving, the need to save things, perceived need to save things regardless of their value. So this can be like trash, this can be things that maybe don't necessarily mean a lot to the child, but they have significant distress when these things are thrown away. Trichotillomania, again, falling not under anxiety disorders, but under the OCD umbrella, but we're talking about them because there's some overlap in treatment. Trichotillomania is hair pulling that causes distress and impairment, and can cause patches of hair loss. Often people describe it as something doesn't feel right with their hair. So they might pull that out, and then that doesn't feel right, and then they pull again. Excoriation disorder is a similar type of disorder that happens with recurrent picking of the skin. To the extent that there can be infection involved, this is different from cutting that we'll see in adolescents in particular. Excoriation disorder is, there can certainly be injury, but the intent is not self-harm. The intent is to even out or because it doesn't feel right. Specific phobia is an extreme fear of a particular thing. Bugs, snakes, heights, public speaking, most common one in adults. And this causes significant impairment or distress. For kids, kids have a lot of fears of stuff, right? Thunderstorms, the dark, going to sleep sometimes. So it needs to be weighed about what is sort of a natural concern and what is a sort of really life impairing sort of specific phobia. And there has to be consistent presentation for 6 months or more. And that can be a big difference in kids, because kids are usually pretty adaptive, where they go through a phase where they're afraid of dogs for a little bit, or, you know, afraid of ladybugs or whatever it might be. And then they move into a new developmental phase, and that seems to kind of go away, and maybe they're afraid of something else. That's more sort of the natural course. This would, specific phobia would be something like, child won't go outside and play because they're worried about ants or something. It would have to have significant impact on their functioning. And social phobia is the fear of situations with peers where the child or adolescent feels like they're going to be doing something, that they might do something embarrassing, and then they will be judged or laughed at by peers. Everyone has a little bit of social anxiety, and particularly during those adolescent years when we're really trying to figure out who we are and what's important to us, and fitting in is so important. But this would be something where there is avoidance. Remember those features of severity and avoidance. This would be sort of extreme, where the adolescent maybe doesn't go to school, won't go to parties, won't interact with other people because of this extreme fear of being judged or doing something embarrassing. Panic disorder is that classic, abrupt, unexpected onset of fear with significant intensity. This is apparent to everyone who is observing the person that having panic disorder. It often looks like a cardiac event, shaking, sweating, shortness of breath. The person appears to be sort of out of it, might not respond to verbal cues, or even, trying to put your hand on their shoulder. They will be sort of out of it. Definitely need a medical rule out for things like panic disorder. Less likely in children. Children might have like a tantrumy outburst. It won't look exactly like panic disorder. Panic disorder does appear definitely in puberty with these sort of physiologic symptoms of the sweating, shaking, loss of touch with reality, and that kind of thing. But again, we usually see panic with the onset in puberty or afterwards. So we mentioned earlier about the infectious hypothesis of anxiety disorders, and it's just worth a note, since we're talking about children, that there are a group of disorders that have been associated with infection. And the first one is the one listed there at the bottom, PANDAS, which is an acronym for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Strep. And that strep is strep infection. It's the classic group A beta hemolytic strep infection, after which an acute onset of psychiatric symptoms occurs. And then that other acronym, PANS, is sort of the next iteration from PANDAS, and it's identified as pediatric acute onset neuropsychiatric syndrome. So in PANS, there might be something else that triggers either something environmental or another type of infection, but these are kind of considered together, since there is some specific pathogen or environmental exposure that results in acute disorder, and anxiety is common in that. So some of the features of PANS and PANDA include, and sudden is key. Notice it's in capital letters and should be underlined and highlighted, that it is a sudden onset of one or more of the following. And that would be obsessive compulsive disorder, tics, sort of movement, eye blinking, shrugging, movements of the face or mouth that are repetitive and out of the person's control. Anxiety, significant sometimes mood lability. Child is laughing a lot one moment and then is very irritable or has an outburst, and sometimes acute separation anxiety. And that would be like separation anxiety disorder. Like a child will wake up and I'm not going to school and demonstrate lots of these symptoms. Oftentimes we can see sort of a preceding even though the symptoms, the OCD, the tics, anxiety, mood lability, and separation anxiety are sudden, sometimes in history taking, we can find that there have been some decreased academic performance, some changes in handwriting, maybe some clumsiness or changes in muscle activity. Say a child who's been a very good athlete suddenly becomes clumsy, very unlike them. So even though the behavioral symptoms come on suddenly, the other symptoms, sometimes parents look back and say, gosh, you know, it's interesting. Yeah, they weren't scoring in the basketball game like they usually do, or they were saying that they were just feeling fatigued with handwriting or that kind of thing. So kind of diving into the diagnosis of these, we would obviously want to provide a good, just general psychological care. But if we identify that there has been, for PANDAS for instance, a group A strep or other infection, we would want to see if there was present infection. And we would look at an anti-DSB titer, ASO titer. Sometimes there's no evidence of strep, which makes it perplexing for this diagnosis, but that is actually consistent with rheumatic illnesses, where sometimes even though we know that there has been a rheumatic fever, we can't say with absolute assurance that there was an exposure to a group A beta hemolytic strep infection. We also see CD4 changes in indicative of overactive immune response, and we see IgG subclasses and total immunoglobulin levels increase of IgA and IgM. So PANS, which was kind of the bigger, the next more inclusive than just strep, we see that other triggers of this acute onset neuropsychiatric symptoms might be related to exposure to mycoplasma, mycoplasma pneumonia, Lyme disease. There are lots of neurological consequences of Lyme disease, and this could be, acute onset of psychiatric disorders could be one of those. Coxsackie virus, molds, Epstein-Barr, and there are even some case reports of responses to influenza. I'm sure since in our current state with COVID, I have not seen any data about acute onset psychiatric disorders associated with COVID yet. So looking at treatment of this very sort of specific subset of anxiety disorders, ideally we want to treat the underlying infection if we can relate specifically to the symptoms to an infection. And there's also recommendation for prophylactic antibiotic therapy. Now, for psych NPs, this would be a collaborative effort with primary care or the pediatric nurse practitioner as far as prescribing the antibiotic therapy and following it. The recommendations include augmentin for 400 milligrams a day or azithromycin for 250 milligrams a day. There's a lot of concern about prophylactic antibiotic therapy because of resistance and that type of thing. If it can prevent severe psychiatric syndromes, obviously it's a cost-benefit consideration there for the team. There can also be prophylactic therapy with penicillin, which would generally be at the 250 milligrams BID. There are also, these are listed as research-based interventions, but I know there are centers that are, and the NIH did the first trial of this for plasmapheresis for treatment of PANS and PANDAS. IVIG, non-steroidal anti-inflammatories can also be used. And just to note there, obviously all these would depend on the age, weight, and tolerability. So that's definitely a subset of anxiety disorders that have an acute onset related to infection. And we'll probably see more of that. And these things, obviously appreciating always the whole body responses to everything in life. All right, so looking at overall treatment of anxiety disorders. So one of the first things we want to think of, since we're talking about anxiety, are lifestyle changes, right? So we want to think about things like caffeine intake. We want to think about sleep. We want to think about sleep always for general good health, but sleep is often really compromised in anxiety disorders. So it's and we'll talk a little bit more about some specific considerations on that. Screen time. Screen time has been an initiative of the American Academy of Pediatrics for some time, and certainly in this COVID time, managing screen time has been an extra challenge because we're completely reliant at this time on screens. So we'll talk a little bit about that. Activities, exercise, relaxation activities, just generally the busyness of the family and the individual, looking at those things, and also looking at family dynamics. We talked about some of the heritability of anxiety within families, and family therapy. Often, if a child has an anxiety disorder, an adolescent has an anxiety disorder, it has family impact. And family therapy, I'm always a strong advocate of for many things, but certainly for an individual that's experiencing anxiety, because it impacts everyone. So we're going to talk about some pharmacologic interventions, but let's talk about first line. That's first line treatments for anxiety disorders in children and adolescents. The very first is cognitive behavioral therapies. These, of course, would need to be appropriate for age and developmental stage. And remember, the goal of cognitive behavioral therapy is to sort of restructure how an individual perceives things. And children, because they have more magical thinking, which is appropriate, for developmental stage, we can really engage that to try to identify, like lots of times in cognitive behavioral therapy, we'll call the anxiety something, like give the anxiety a name. What are you going to name your anxiety, or whatever words they use to describe what that experience is. And then they will talk about strategies. Worked with children who use, they might use little like army figures, or, even Pokemon, or, and they create their sort of what gives them power to manage their anxiety, what their strategies are. And they kind of make it a game, with the whole restructuring of looking at anxiety a different way. And cognitive behavioral therapy, which there are many sub-therapies under that, I'm kind of using it as a placeholder for many types of therapies, really focus on the strengths of the individual, and also sort of naming and claiming the anxiety, which has been a little bit of a change, because the focus used to be, and this is, a little bit longer ago, but to try to avoid anxiety and try to avoid situations that resulted in anxiety, which is really inconsistent, as we've been talking about, with life. So the more common thought now is to identify it, but set parameters around it, and to help the individual experiencing it, like, I'm in charge here. All right, anxiety, I call you this name or identify you in this way, but I have these tools and I'm in charge. So kind of embracing it and incorporating it and controlling it. Sometimes sort of theatrical, even puppets, to give name and identify what the anxiety is going to be called, and how the child, sort of manages that and takes control of it. Identifying feeling states, and one of those strategies, one, to be able to use language and pick language that identifies how they're feeling, but to also help them learn sort of basic body scan techniques. So when they are feeling a certain way, we'll ask, so tell me what's your body doing right now? What are your shoulders doing right now? What's your face doing right now? Which helps them sort of pause, and then also helps them dial in to what's happening with them and what responses they might employ. It's a whole, depending on the type of cognitive behavioral therapy, there's a whole stepwise strategic expectation of how that therapy goes. Obviously, it's individualized for the person, but the goal is to sort of restructure how they look at their anxiety and how they'll manage it. So behavior therapy is very effective with children. Again, first and foremost, we have to consider the developmental age of a child. So if they're in a concrete developmental stage, behavior therapy, which is kind of very specific and based on reward, can be very helpful. And behavioral therapy is the treatment of choice for obsessive compulsive disorder, where, for instance, a child has maybe a concern about dirt and germs, and they are asked to not wash their hands for a certain period of time. You might set a timer and then help them do breathing techniques or body scans or talking about how they're feeling to try to decrease the anxiety, since they won't be able to wash their hands until the timer goes off, 10 minutes, 3 minutes, 5 minutes. There's a stepwise approach. Again, all these therapies have very specific parameters of how they work, and the family and the child who is experiencing the anxiety needs to know exactly what to expect in therapy. But for behavioral therapy, again, then the timer would be a little bit longer, and they would learn to manage that. The goal is they would learn to manage that anxiety and identify it for what it is so that they can still proceed with their life and not be dominated by it. For specific phobias, there is exposure therapy, less common with kids because an exposure therapy is a progressive exposing someone to their feared stimulus. So an example, for instance, that we do with adults, for instance, fear of flying. So, and this would be more, again, an adult example, but someone's afraid of flying. So in exposure therapy, the first day, we might stand outside and look up in the air and watch airplanes fly by. And obviously give folks skills about how to manage their responses, their physiologic responses and emotional responses to that feared stimulus. And then one part of therapy might be driving to the airport and watching planes closer. Next part of therapy further down the line might be boarding an airplane or a simulated airplane. I personally live not too far away from a major international airport, and they have a whole program for desensitization therapy, exposure therapy, that includes a simulated cockpit that people go in and sit on, and with the goal of being able to advance to be able to go on a flight. For kids, again, because of their insight, the exposure therapy would be very modified, and there would be child specialists to engage in that. For social phobias, more supportive therapy, self affirmation, support, and definitely some cognitive behavioral therapy for restructuring how they perceive themselves and how they perceive that the world perceives them. And we mentioned earlier about family therapy. Anxiety disorders affect everyone in the family. There can be, people will say, if it wasn't for my sister's anxiety, we could maybe go on vacation or go somewhere. And so it impacts everyone. So family therapy is always a recommendation, of course, if people are willing to engage in that, because it is hard work, but ultimately it does, these disorders and every disorder affect the entire family. So let's talk about sleep for a second. Sleep, again, important for everybody, always, all the time, but is often really impacted and affected when people are experiencing anxiety disorders. So we know if a child is up at 3 a.m., somebody's going to be up with them. So again, it kind of affects everybody. And just a note on the established goals for number of hours of sleep. Preschool age children, anywhere from 10 to 13 hours of sleep, maybe more. School age children, 9 to 11 hours of sleep. And teenagers, yes, should be getting 8 to 10 hours of sleep. Teens are naturally phase altered. It's actually neurobiological that they want to stay up later and then get up later. With modified school schedules now, sometimes that has been a plus for teens, but they really need that solid 8 to 10 hours of sleep. And what's interesting about sleep for the aspect of working with children, that's when growth hormone is secreted. So children with anxiety disorders might actually be of shorter stature because of that impact of lack of sleep and increase of anxiety that might actually suppress growth hormone. Okay, so for sleep hygiene, the first step is establishing a routine. Everyone needs a bedtime routine. There should not be any screens, and sometimes, you know, now people have the blue light active glasses that kind of decrease that impact on the brain, that stimulation, but screens are still discouraged at least 2 hours before sleep. No electronic devices in the room. No phone, no gaming equipment. There should not be any lights that are activated and or potentially flashing in the night. No caffeine after 3 p.m. and no exercise after 5 p.m., which sometimes is interesting because we know that exercise is part of establishing healthy sleep routine, but it can be activating if you exercise too late in the day. So we'll encourage no exercise after 5 p.m. And of course, while we're talking about adolescents, and look at this slide, no screens, no electronic devices, no caffeine, no exercise. We're gonna have to reframe that for adolescents. Let's try that slide again. Create your own bedtime routine. Finish looking at screens 2 hours before sleep. Move all your devices out of the room for the night. Complete exercise before 5 p.m. and consume all caffeine before 3 p.m. That sounds a little bit better. Adolescents don't like the word no. Well, no one likes the word no, but we want to have a positive, upbeat approach. Okay, a little bit more about sleep. And it seems like we're spending a lot of time on sleep, but it's worth it. So melatonin. Melatonin, remember, is not an approved medication. It's approved by the FDA only as a nutritional supplement. Some supplements do contain serotonin, again, not regulated, so we can't really know, can't endorse a particular brand, whatnot. And we do want to have caution of children that have a history of seizures, any type of seizures. Generally, melatonin is considered very well tolerated and very safe, but I'm always cautious and usually don't recommend it if a child has a history of any type of seizure, even febrile seizure. Our starting dose for kids is 0.5 to 1 milligram, taken 90 minutes before bed or up to 2 hours before bed. I think that has, and lots of times when you read the label, melatonin says, oh, 20 minutes before bed. The way melatonin works, it prepares the brain for sleep. It's not like a sleep aid. It's not instantaneous. So it needs to be taken early enough for people to have good effect for them to be able to go to sleep. For kids, max dose, absolutely 3 milligrams to 6 milligrams. But I always start really low. And it's amazing that what the lower doses can do in addition to sleep hygiene. All right, so let's talk a little bit about some of the pharmacologic treatments for anxiety disorders. And I'm presenting the medications that are FDA approved. Please know that we do a lot of off-label prescribing for children because the investment in research, the statute of limitations, having, recruiting and putting children at risk in pharmacologic trials, it's very limited. So this is what is approved. And one of the reasons I talked about obsessive compulsive disorder was because there are quite a few medications that are approved for use in children with obsessive compulsive disorder. We use them off-label as well for anxiety and also for depression. But the reason that they're here, because that's what they're approved for. They're approved for use with OCD. So we do have pharmacologic data on them, again, for OCD, but we can, as far as safety, we can transfer some of that information to children with anxiety disorders. So sertraline, the SSRIs are preferred in treatment of anxiety disorders. And for OCD, anyway, the dosages are pretty much the same for anxiety disorders. Zoloft, and for ages 6 to 12, 25 milligrams per day. And both sertraline and fluoxetine, Zoloft and Prozac are available in a liquid, which is always helpful, particularly in younger children that have difficulty taking pills. And you can also then make modifications in the dose that are can be in lesser milligrams if you have it available in liquid. And for children, we always want to start really, really low for dosing, because that can make an impact and can help us avoid some of the side effects that can happen. Zoloft is also approved, of course, in children over the age of 13. And generally for our teenagers, we use adult dosing, starting in 50 milligrams with a cap of 200 milligrams a day. But again, we want to go as low as we possibly can. Prozac, fluoxetine is kind of our gold standard. It's been around for a very long time. Relatively well-established safety data. It's approved for children as young as 7 and can start at 20 milligrams a day. Like to start definitely a little bit lower than that for anxiety disorders. And we had mentioned that that's available in liquid form as well. Fluvoxamine, also trade name Luvox, is available, is approved for children ages 8 and older. And they're the established doses, 25 milligrams up to 200, with BID dosing with greater than 50 milligrams with larger dose at bedtime. We generally want to dose these. Children have a similar response as far as activation as we do with adults. So Luvox there is probably the only one that we dose the larger dose at bedtime. And it depends on how the child reacts. Sometimes these can be sedating or sometimes they can be activating. We do have a tricyclic that's approved for use for obsessive compulsive disorder. This is clomipramine, also known as anafranil. It's approved, FDA approved for children ages 10 and above. We rarely use this first line because it's tricyclic and because of the potential cardiac issues. We do usually get to baseline ECG because of that, and really sort of this would be for someone who was treatment refractory, even though it is approved and there are some, there's supportive data for use. Because it's a TCA, we really kind of steer away from it with kids. So if you're looking for the long list of medications specific for treating anxiety disorders, we have a grand total FDA approved of 1 for generalized anxiety disorders in kids. And that's one that you probably wouldn't expect. It's duloxetine or Cymbalta. It is approved for children that are older than 7. Our usual start, and again, it varies a lot for kids. We want to go as low as we possibly can in our starting doses. But generally 30 milligrams start. And of course, Cymbalta is a serotonin norepinephrine reuptake inhibitor. And there are a little bit more reported adverse effects with the SNRIs compared to the SSRIs. And these are usually related to GI side effects. So of course, we're talking about anti-anxiety medications, right? But these are the medications that are approved for use in depression that lots of times we use with children that are having primary presentation of anxiety. And these, again, are SSRIs, are pretty much our gold standards for kids with anxiety disorders. Prozac, we talked about, again, FDA approved for children older than 8, generally 5 milligrams to start. And our notes on all of these SSRIs, and includes the SNRIs because they contain serotonergic agents, is the risk for increased suicidal ideation. This is known as the black box warning for anyone who's 25 years old or younger. So we are very, very vigilant in getting baseline risk for self-harm assessment and watching that very closely, particularly the first 1 to 2 weeks of treatment, which is often, we see someone for follow-up generally in 2 weeks. I always like to make a call after the first week, or sometimes even the first few days, to see how things are going. And the other medication that we haven't talked about yet is escitalopram, or Lexapro, which is approved for antidepressant use in kids for children older than 12. And that has a 5 milligram start, is available in liquid. We have, in both of these medications, a risk for discontinuation syndrome. So, and that's relevant for everyone, but adolescents in particular can get frustrated if they're not experiencing the response that they are hoping to get. They might stop taking the medication suddenly. So I always want to have really frank conversation with them, since they are in charge of their health and it's their life, that they can have some significant discontinuation syndrome. And so if they feel like it's not working, to please reach out, please keep taking it, unless you're having something else. Talk about the suicidal risk, which we want to see them immediately if they're having any of those feelings. But to have them contact us before stopping suddenly. So we would, if we're talking about anxiety, right, we have to consider possibility of using benzodiazepines. We are very vigilant, of course, about benzodiazepines because of the risk of dependence on them. In the literature, there is just all kinds of discussion about whether or not this is useful, and particularly in kids. And it's really provider, patient, family decision-making tree to whether or not to use these potentially short-term. We have proven efficacy for the reduction of anxiety, for instance, for medical procedures for children, but there's much less data out there about helping with anxiety. However, there can be a place, potentially, depending on the provider, again, family, shared decision-making, about using benzodiazepines short-term so that the other therapies can be effective. We do have very little data about the psychiatric uses in children, but we do have excellent data to support tolerability and effectiveness for use of children before medical procedures. So there is a precedent there, but again, we have very limited data, and there's always that concern about the risk for dependence. Other sort of concerns in monitoring the medication, we talked at SSRIs about the potential increased risk of suicidal thoughts. So we have a lot of discussion about that with the child and their family, and things to look for, and ways to record how they're feeling. Sometimes more so than in adults, there can be activation in children, which is usually demonstrated as irritability and trouble sleeping in kids. This can be more significant in children than adults, so it's something that we want to watch, and another reason to go with as low a dose as we possibly can. And we definitely want to, if we're discontinuing a medication for whatever reason, we want to schedule for taper and not to have an abrupt discontinuation. So let's talk in our last few minutes here about anxiety and COVID. When we first decided to do this presentation a couple of months ago, I think we were thinking there might be a lot of data out there, and knowing the speed of science, it was probably a little ambitious to think that. We have very limited information at this point about the impact of COVID and the pandemic in general on anxiety. We do see some trends. We know that people who were struggling before the pandemic are still struggling. We know that issues related to violence in the home and substance use have increased for certain folks, and that it is a really, really tough time. As far as trends in data, since I want to share what's out in the data, the majority of information that we were able to assemble occurred from outside the US, which might be because there were cases happening long before in other areas, but most of the data that we could capture was from outside of the US. Where there are many citations of the development of screening tools and scales. They are currently being validated to evaluate the impact of COVID on mental health. And we know that there is an increase in screen addiction. There's some reports about increased also addiction to porn because of that access to screen, and we mentioned earlier, and it's definitely true that there have been changes in substance use, mostly increase. So we're going to have to just present some excerpts of what we have been able to see, and some of these are from published reports in newspapers and other types of media. There was a survey published from June 4th that surveyed 1,000 United States teens. So this was done in the US. They were between the ages of 13 to 18, and this is just a percentage report of, and this was related specifically to financial concerns or worries. So in this survey, 72% of the teenagers surveyed had asked their parents about the financial impact of COVID, and they were worried about what was maybe happening to their family. 30% of those surveyed had changed plans post-college. These were generally the older teens that were getting ready to go to college, either this fall that's currently happening or in the next year. Some of them have postponed college altogether. Others know that their family are aware that their family doesn't have the resources to put them in and to continue in college or to go to college. Others have just chosen to put a pause on life until things settle down. And 60% of those surveyed said that they're worried about someone in their family getting sick. One of the disorders that we might expect to increase with related to COVID, since it's an infection, would be obsessive compulsive disorder. And it was interesting that there was a study done in 84 adults with OCD, and there wasn't really a significant statistical significance increase in symptoms. However, there was another study done with children with obsessive compulsive disorder who found a significant increase in symptoms, specifically, and it makes sense, right, related to contamination fears and washing rituals. There was, and this was a single report out of Ireland that talked about teens experiencing significant stress during COVID. This particular researcher found an increase in depression in the population that she surveyed, and found a specific increase in depression for LGBTQ youth, particularly if they were in a home that was not particularly supportive of them. This was one interesting finding, that some of the teens experiencing bullying, academic or social stress, actually had a reduction in anxiety when schools went to virtual delivery, which is interesting, in thinking about what happens on the reentry side, whether or not we'll, see a significant increase. So some things we do know about, and this is an ongoing thing as we enter particularly some of the fatigue related to the pandemic, to continue to maintain routines as much as possible, to try to continue social activities while wearing a mask and following distancing guidelines, sort of that gradual re-entry with friends and activities as long as they're within the safety parameters. Allow children to talk about their feelings. I think lots of people are, and rightfully so, saying sick about talking about COVID. We just want to be done with it. So people are having an extra fatigue on top of the ongoing uncertainty. So always allowing children to talk about their feelings, and use expressive play. Also to be honest. For parents and families, teachers, anyone who interacts with kids, to be honest, but also to be protective and realize that the information you share should be within the appropriate developmental level, to not worry children or teens beyond what they can make sense of. And of course, if anyone has concerns about a child, about their safety, to contact the National Suicide Prevention Lifeline, which is provided here. and to not hesitate if someone's worried about someone to make a call, encourage them to make a call or make the call for them. All right, so thank you so much for joining us today. Let's end on a positive note. Let's remember, above all things, children and adolescents are incredibly resilient. They have resources that I think as adults we kind of forget. They are very resilient. Anxiety disorders can be cured. Even very severe anxiety disorders can be cured. Help is always available. Telepsychiatry is booming, and we will continue to see changes, I think, that are just better for patients as far as accessibility and ways to get the help people need. And the good news, history tells us that pandemics really do end. We have data that they really do end. Maybe not as soon as we wanted them to, but they do end. Thank you so much for joining us today, and we appreciate your attention and the celebration of Nurse Practitioner Week. Thank you.